Today, we will be conducting a clinical review of bacterial vaginosis, focusing on the diagnostic nuances of this common dysbiosis and the evidence-based guidelines that dictate our management in both general and obstetric populations. When managing vaginal health, we must recognize that bacterial vaginosis is frequently a subclinical condition. Current epidemiological data indicates that 50% to 75% of affected women are entirely asymptomatic. Consequently, clinicians should maintain a high index of suspicion, as the absence of a patient complaint does not necessarily rule out a significant shift in the vaginal microbiome. A critical diagnostic pearl is the distinction between vaginosis and vaginitis. Bacterial vaginosis is a dysbiosis, not a primary inflammatory process. Therefore, it is typically characterized by a notable absence of mucosal inflammation, erythema, or edema. If a patient presents with significant pruritus, dysuria, or dyspareunia, your differential should immediately expand to include mixed vaginitis, specifically looking for a co-infection with Trichomonas vaginalis, or Candida species. In terms of microscopy, a diagnosis is supported when greater than or equal to 20% of the observed epithelial cells are identified as clue cells. These are pathognomonic, epithelial cells so heavily coated with coccobacilli that their cell borders are completely obscured. Furthermore, the amine whiff test remains a cornerstone of the AMSL criteria. The primary goal of therapy in bacterial vaginosis is the resolution of symptoms and the restoration of a balanced microbiome. The current standard of care involves a 7-day course of either metronidazole, administered orally or intravaginally, or clindamycin as a 2% cream. One of the most frequent clinical inquiries involves the management of sexual partners. It is critical to note that bacterial vaginosis is not traditionally classified as a sexually transmitted infection, but rather a complex dysbiosis. Extensive clinical data has demonstrated that routine treatment of male sexual partners does not reduce the rate of recurrence in the patient. Consequently, partner treatment is not recommended and does not impact clinical outcomes. Finally, we must address the management of BV in the obstetric population. While there is a documented statistical association between BV and preterm delivery, clinical trials have consistently demonstrated that treating asymptomatic BV does not lower the incidence of preterm birth. However, selective treatment of asymptomatic pregnant individuals with confirmed bacterial vaginosis may be reasonable, such as for patients with previous preterm births.